Dr. Ziedonis is professor and chair of the Department of Psychiatry at the University of Massachusetts Medical School. He is professor for the Graduate School of Nursing and Graduate School of Medical Sciences at the University of Massachusetts Medical School and UMass Memorial Healthcare. He is also president of UMass Memorial Behavioral Health Services and a Spark faculty member. He is an internationally recognized expert in co-occurring mental illness and addiction, leading and advising on numerous international initiatives in tobacco addiction and mental illness. His current work includes new research and development of the recovery-oriented Finnish open dialogue approach to mental health treatment for implementation in the United States, including developing 12 key components of dialogue practice and the 10 organizational criteria for open dialogue. And with that, I'm going to turn things over to Dr. Ziedonis.
Well, thank you so much for that generous introduction. It's great to be online with all of you as attendees. This will be a webinar where we don't get to see each other's face, but we will have the PowerPoint and be able to have conversation, and I look forward to the questions at the end. Even though this isn't a CME and I don't need to provide disclosures, I just thought to put it out there, no financial arrangements with any pharma or device commercial interests, and these are the research grants and advisory boards and board of directors that I serve on. Today there will be sort of two main, which will be one to help us think about how to create motivation-based, recovery-oriented treatment plans for co-occurring disorders. So obviously there's many types of co-occurring disorders, and oftentimes we don't put people in our the details of the co-occurring in the treatment plan if we don't think they're motivated. So I'll be really encouraging that if you've identified an issue to include it in your treatment plans. Two, we'll talk and hopefully get into details on how to integrate recovery-oriented practices into your work, including dual recovery therapy, which is a model that I've developed, and there is a online resource that you could get this manual for free that I'll tell about later in the presentation. I'll also talk about mindfulness-based interventions that are becoming more commonly used in addiction treatment and in mental health treatment. Motivational enhancement therapy, MET, a derivative of motivational interviewing. And for certain problems, there's a lot of community resources, others less. And 12-step is really available for any type of substance and also for dual recovery. Since some of you are coming from mental health and some of you are coming from addiction, most people don't know as much about tobacco use disorder, so I thought I will focus on that as a case example to sort of have us in a practical way think through some of these other issues. I think all of us know that there are very high rates of co-occurring disorder in the general population. It's thought to be as much as 50% of the population has some combination, but if you included tobacco, it might even be higher. Very high rates in mental health settings and addiction settings if you're in the inpatient or outpatient setting. But co-occurring disorders is really a misnomer. It's not just one thing. It's a combination of many diagnoses, oftentimes several substances and maybe a couple mental illnesses also. What's clear is that people who have co-occurring disorders have more complexity, and there are more consequences, homelessness, and I'll talk about some of the homeless programs that we have and resources, since that's most people who are homeless have a co-occurring disorder. Trauma, and I know a number of you are interested in the issue of trauma. People may perpetrate or be a victim of trauma. And then medical consequences are also large, let alone legal and other problems that are either social or medical. Integrated treatment is also a buzzword that brings together the best of mental health treatment and the best of addiction. And sometimes there's a modification. So other kinds of dual recovery therapies might be examples Seeking Safety by Lisa Najovitz, which is a great program for trauma and addiction, which again I know a number of you have expressed interest. And how do you not only integrate the treatment, but how do we create integrated programs and coordinated systems and services along levels of care? In the introduction, open dialogue was another model that, although it's not a co-occurring disorder model, it does have a lot of the principles that I've actually previously used in treating co-occurring disorders. So I'll focus on the psychosocial treatments given who the audience is. I will mention a little bit about medications, and particularly on the substance abuse side. There are a lot of resources, and I'm going to start off with a great resource that SAMHSA provides and how you could access it. But if you look on this line here, the VA has practice guidelines, American Psychiatric Association, so lots of guidelines for treating co-occurring disorders. Recovery is a long-standing word in addiction treatment, and in the last 25 years has become more commonly used in mental health settings, and I think co-occurring disorders has really been the leader in getting the word of recovery into mental health treatment. Being wellness-oriented, in the addiction literature, there's phase 1 recovery and stage 1, and then there's a stage 2 recovery. Ernie Larson, L-A-R-S-E-N, has written some great stuff in this area. And in that second stage, people work on their personality quirks and get better connected to their social network of support. And it's also important to think about their physical wellness in addition to spiritual and mental health. And this is often a time when the 3 issues of tobacco, obesity, and stress is a good time to address it in stage 2 recovery. SAMHSA, if you put in your search engine the HHS publication that's listed there, SMA 124689, you can download a free manual that SAMHSA has put out on the 14 principles in treating co-occurring disorders. It's a great resource, and they have one very similar to it for the particular topic of trauma and addiction that, again, I know a number of you are interested in. So some of these I'm just going to go through quick. Hopefully there are more of guiding principles. The manual has a lot more detail on this, but how do we engage? No door is a wrong door. How do you help people feel welcomed and open lots of options for them with treatment? In any treatment process, probably the most important thing is the relationship building and how you connect to other people, how you provide that sense of hope. That had been kind of the biggest barrier for co-occurring disorders because clinicians only knew one side of the treatment and often felt hopeless with trying to help people. How do you be strength-based, recovery-oriented in developing that relationship? Another great thing about the open dialogue model. Shared decision-making has become more of a routine, but how do we really do that shared decision-making? And there are tools that are available. These are some helpful ones if one wanted to learn a little bit more detail about shared decision-making. And I'm not going to go into those in detail, but you may want to look those up. I'm going to talk about a case today about smoking and schizophrenia. So here is an online interactive tool that could be used, and this was based on the Cochrane report of what data makes sense as far as medication for smoking cessation, and really educate the consumer as they think about the different choices. So that could be a supplement to what you might do by yourself clinically. As we begin to talk about medications, particularly in co-occurring disorders, I think it's important that we think of the psychology of taking medications for someone who has a substance use problem where they're thinking that the pills fix the problems and there's a quick solution. But with addiction, there's vulnerability there, and one has to have a lot of thought going into thinking about medications and talking with people about it, and I'll talk in more detail about that. Other principles from SAMHSA: screening and assessment, and I'll talk about some details in the tobacco as an example, but getting both sides of the fence, trying to deal with adherence, maybe lab testing is important, toxicology monitoring, not as common a thing in mental health settings, but important to do if you're working in substance use. Assessing, if you want to put a timeline and got input from the significant others, the social network, again, another model within the open dialogue approach. Sometimes substances can mask or make something look like a mental illness, even though it's a substance-induced mental illness. So teasing that apart over time is an important issue that requires more dialogue than can be done today. Integrating interventions, both are really primary issues that need to be addressed. So what are those best practices? DSM-5 is still somewhat new to a lot of people, so I thought I'd quickly review it for substance use disorders. There's no more substance abuse or substance dependence in DSM-5. Everything is a substance use disorder, so it might be tobacco use or marijuana use or alcohol use. So what did DSM-5 do? It blended, in the first column you can see the 4 criteria of abuse. So it includes 3 of those 4, but not legal, if you look on the far column on the right. And DSM-4 for dependence included the 1, 2, 3, 4, 5, 6, 7 criteria. All 7 are part of substance use disorders. And most of us as clinicians know that craving is a big issue in substance use disorders, so that's been a new criteria. So you have 11 criteria, and all you need to do is have 2 to meet substance use disorder. So mild is 2 or 3 symptoms, moderate 4 to 5, severe is greater than 6. There's now no polysubstance category. You have to really spell out each one. Obviously, with co-occurring disorders, not only the baseline assessment, but ongoing assessments for changes in mental status, changes in use, cravings, thoughts they might have, and also motivational levels will change. Are they compliant with their treatment, meds, therapy, and are they engaging in a 12-step support network? So integrated psychosocial treatment, this is the framework for my dual recovery therapy, which I'll give you a resource on very shortly. But most integrated treatments for co-occurring disorders are blending one of these or multiple ones of these traditional addiction treatments like MET, relapse prevention, which is the cognitive behavioral therapy approach, 12-step facilitation, or mindfulness-based interventions, with the evidence base for mental illness. And there's many specific types. So here's a free resource. So if you go to www.missionmodel.org, you can download for free these manuals that, although were developed in the VA for veterans, these really could be used clinically on an individual or group level, and the DRT is in that manual, as well as for case managers and multiple different clinicians on the clinical team, and there's a manual just available just for the consumers. This has become now the model also for the homeless in the state of Massachusetts, who may be veterans or not. About a third of the homeless are veterans, sadly. Continuing with those 14 principles, readiness, people's motivation. You got to meet them where they're at. Got to assess the motivational level, look for relapses. How do we have interdisciplinary communication? And open dialogue takes that to another level. So for those of you who might want to learn more about it, that won't be the focus of this webinar, so I'm just going to give you another resource. You could put in your Google search engine UMass, U-M-A-S-S, open dialogue, and you will get our web page where you can download a free PDF that will give you a great introduction to open dialogue. We now have studies in Europe, so if you speak Italian, you can download the Italian version, and soon there's going to be a Mandarin Chinese and a Japanese Japanese and a Latvian and a bunch of other countries. So, but for interdisciplinary communication, there's a lot of great ideas in there. Integrated treatment, how do you put it together in a treatment plan? So let's think of a case here. So I want you all to, maybe if you have a piece of paper nearby, I'm going to ask you to take some notes for yourself as far as how you might answer some of the questions. So schizophrenia and tobacco use. 39-year-old individual, person doesn't want to quit now, is on the medicine of olanzapine, has obesity, hypertension, a carbon monoxide level of 43. In your mind, is that a big number, a little number? We'll talk about that later. Olanzapine, is that something I have to worry about? Will the blood levels of that change if someone stops smoking? Because that's an important clinical issue with people who are smokers. Person lives in a group home with other smokers, so that might make it difficult to quit. I'll make the case easy, no history of alcohol or drug use. And also, the person is drinking 8 cups of coffee a day. So is that a clinical issue we would have to worry about when somebody quits smoking, if they would? So how would you assess this individual? Well, you could do more mental health assessments, see where they are with their schizophrenia psychosis symptoms, what meds they're on, what strengths they have, what's been helping them. And how would you think about the tobacco use? So whether it's tobacco or any other substance, there's usually something about quantity and frequency, although the definition of an alcoholic isn't someone who drinks more than you. So it's not just about frequency, but that gives you a clue. For heaviness scale in the tobacco literature, time to first cigarette, TTF, or cigarettes per day gives you a clue. If they have a cigarette in the first 5 minutes, that's not good. If they have more than 20 cigarettes in a day, again, another problem. So like any other substance, what are some of the cues, triggers, people, places, things, mood states that might be associated with craving or use? The specific objective tests in tobacco would be a carbon monoxide meter like an alcohol breathalyzer, or a cotinine level that can be obtained from saliva or blood or urine. So there's many sources for that to get levels. I think it's important to get these, and we have them routinely in our programs. Have they tried to quit before? How successful were they? What did they try? Did they use the medicines correctly? Did they try any psychosocial treatment? Most people just try meds. It's the only substance that we treat mostly with meds, not because it's the right thing to do, but because it's easy. What's their motivational level? Do they have some support? Like you think about that guy in that case. Are they on any other meds or caffeine, substances, or other medical problems? So in the case of this individual, olanzapine is a medicine that does get metabolized through a certain part of the liver, the 1A2 isoenzyme. So does caffeine. So they change. Their blood levels change. When you smoke a lot, you need to have a higher level of medicine and caffeine, and then when you stop, you often can have a lower level of that kind of medicine and and caffeine. Again, I would encourage people to Google search. We have handouts on this material for medications that are affected by tobacco use. You'll be able to find that online. Great handouts. Electronic cigarette, you've heard a lot about. Some of you may have questions about. I'm not going to talk about it in too much detail other than to say this is what it looks like. The cartridge is where the medicine is, or the nicotine is actually put in, and the atomizer makes it breathable, combustible, and the battery is where the tobacco would look like the tobacco should go. There are a lot of different doses. Some of the cartridges have very high amounts of nicotine. So it's not FDA approved. We don't know if it helps with cessation. It could be more harmful. We know there's some carcinogens and other problems in it. Just like cigarettes, they're targeting adolescents with candy and chocolate and bubblegum flavoring. Our patients often use the little cigars, and if you look at that compared to a cigarette, It doesn't look very different to me, but because it's a little cigar and called a cigar, they don't get the big tax, so they're a lot less expensive. So those are common for our patients. And obviously these are the other types that are a little bit more common in the hookah bar. So what have they tried in the past? Why did they try to quit? What happened? These are all important questions to ask about. So let's get a little more information about this individual. So they started typical adolescent, smoke 2 packs a day, 40 cigarettes a day, wake up in the middle of the night. That's important because it shows how level of withdrawal they have. They still have a cigarette quickly, time to first cigarette. They've tried to quit in the past, which is great, but they weren't successful, but they've tried a couple of ways. It used to be that if you smoked on the patch, people would stop your treatment, but the FDA has changed the rules so that there is more tolerance about using different nicotine replacements together and waiting longer if people are having a few slips on the patch. So this person doesn't want to change. You could assess motivation in a deeper way. So one might just say, are they motivated to quit now or not? One might get a more complicated way, like the different levels, the pre-contemplator who doesn't want to even talk with you about it, a contemplator maybe wants to talk but doesn't want to do anything. Preparation, who might do a few things but nothing serious, versus action, they're ready to go. Some of the tools above, importance, readiness, confidence ruler on a scale of 1 to 10, how important is it for you to quit? And the person says 3, and you say, oh, 3, that's pretty good. How comes you're not a 2? So that's a motivational interviewing strategy. You could have a whole webinar on motivational interviewing, and there's a great website, motivationalinterviewing.org, that has a lot of great material that you might want to look up. If you're a researcher, those tools on the bottoms, the Socrates and the Eureka, are available. So what would you do on a treatment plan? So I'd like you to sketch on the side there. So here's a low motivated person, doesn't want to quit. What would you do for this individual? What psychosocial treatment or educational material? Would you even think of a medicine or community resources? At minimum, we hope you all put tobacco use disorder on the problem list and consider the motivational level to document it. So for this one, it might say, willing to talk but low motivated, doesn't want to quit now. But there are a lot of materials you could give the individual. There's motivational enhancement therapy that you could do as a treatment. We have a manual, another one I'll show you in a second, that you could use for the low motivated, called Learning About Healthy Living. When I was at Yale University in the early 90s, I developed Learning About Healthy Living for other co-occurring disorders, not tobacco, because people who aren't motivated don't want to go to dual diagnosis groups or co-occurring disorder groups. But if you call it Learning About Healthy Living, they're more likely to go, because most people have some sense of want to make their life better, even if they're using. Medication treatment, one could consider using nicotine replacement in settings where they're not supposed to smoke, and to try to hold them over until a later time when they may pick up and smoke again. Again, this is more of a non-research based but clinical based of what people on their own will do. Nicotine Anonymous is a time where people often go and get information even if they're not ready to quit. So for lower motivated, you might use some feedback tools and use motivational enhancement therapy. Another strategy is to do behavioral disconnects. So like telling the patient, please don't quit smoking if you don't want to, but maybe you could stop smoking in the car, and then giving them some strategies of not smoking in the car or in their room or in some setting. So that will increase their self-efficacy, that they could actually stop smoking in a context, and they could then build on that in moving more towards a total abstinence model. I'm going to give you a way to get the Learning About Healthy Living groups in a second. So this is a carbon monoxide meter. That white thing on the bottom, there's a plastic part, and then there's the paper part that a patient would blow into. So here's someone who blew at 22 parts per million, which is about half of the patient we're talking about today. And that on a 22, 4% of his red blood cells are filled with carbon monoxide, therefore not working. So as you can imagine, a 40 is going to be a lot higher. So here's a person, and when you use this machine, it's a very powerful feedback tool for patients, any kind of patients, whether they have schizophrenia, which we've done research on, or people with medical problems, already have one cancer. The number is scary to them. You can make it with colors so that there's a red, yellow, and green, and you can also make it with a loudness. Another factor of personalized feedback is cost per year. If you ask them how much they spend a day and then do the multiplication, that can be a great source of reflection. If they're spending $2,000 to $3,000 a year on cigarettes, that might be a quarter of their income. We have a whole list of medical conditions affected by tobacco, and you can find that checklist in the back of the Learning About Healthy Living manual. Here are some other things. Personalize the message for the person. Role model can be for some an important issue, giving them more freedom. They don't have to be tied down to the cigarettes and the smoking, how it might affect their life. A lot of people, when they find out that their pets are affected by smoke, stop smoking in their apartment or their house. They never imagined their pet would die early because of smoking. If they work, these are often factors also financially. Motivational enhancement therapy is motivational interviewing plus that personalized feedback. OARS is a standard acronym of open-ended questions, the O, affirmations A, reflective listening, and summarizing. If you're really doing motivational interviewing, you're listening a lot and you're reflecting a lot. So you're not really giving a lot of advice, but you're having a dialogue. This is the manual that I would encourage. If you put Learning About Healthy Living in your search engine, this PDF will come up. It has both a lower motivated material that could be used in a group or individual sessions, and it also has for higher motivated individuals information. So there's two groups, and and it has an appendix for a lot more details. So now you've done a great job on motivating the person through the group and your personalized feedback. So now they want to quit. So again, jot down on the piece of paper next to you, what would you do now? Now they want to quit. How would you think about what medicine you might try, or what psychosocial treatment, or what community resource would you do? Well, I'm going to sort of cover a couple more principles from SAMHSA, and then we'll go into some treatment planning for that specific question. So pharmacological strategies have to think of drug interaction and toxicity, if there are any crossover benefits in co-occurring disorder, and what's the risk-benefit assessment. Thinking about how to coordinate treatment, medical comorbidities, coordinated treatment, and watching for relapse. So for this patient, and that ends really the 14 principles, and I encourage you to get the manual. It'll have a lot more details, particularly for those of you who do a lot of work in this area and particularly have questions around medication management. So you would want to put both schizophrenia and tobacco use on the problem list, mention the updated motivational level, again, still providing those resources. Psychosocial treatments, now you can move to more of a quitters group, which you could use in the back of that other manual, or some of the things I'm going to talk about in a second. And then medications, in addition to the treatment for schizophrenia, and there's some that seem to do better with people quitting smoking, and there are others that are also changed when people quit smoking that we'll talk about. Here's a great time for peer support specialists who are focused on wellness, or people who've just quit on their own in the past, and that's a great resource of NIC-A. We use that in the hospital at UMass Memorial on our consult service, where the NIC-A meetings are actually available online and on a phone, and you can listen in and not have to talk, or you can listen in and talk. So again, I would encourage people, if you haven't used Nicotine Anonymous, there are meetings that are local, but you might also want to go to a phone meeting to be able to listen that way. So there are 7 FDA-approved medications. 5 of them are nicotine replacements. There's a patch, a gum, a lozenge. Those are the ones that are available over the counter also. And then there's also the spray and an inhaler. The spray is in the nose, and it's the fastest one to the brain. Sometimes used well in co-occurring disorders, particularly people who have high amounts of cigarette use like this person. The inhaler is something you would toot on. It's, you're not breathing it in your lung, you're just breathing it in your mouth. So the gum, the lozenge, and the inhaler are all absorbed in the mouth. As nicotine replacements, they're fairly safe. They're safer than using a cigarette, but every medicine has side effects, and it's usually whatever part of the body is touched by these products is where you might get some type of either rash or redness or reaction like the spray in the nose affecting the nose. Most of you will know about bupropion as a antidepressant, but it's also used for helping people to quit smoking, similar dosing, and varenicline Chantix is probably one of the more common ones and single agents used. Psychosocial treatments, similar to any other substance use problem, there are cognitive behavioral therapies, relapse prevention, mindfulness-based interventions, and social support. So with CBT, for no matter what the substance is, what are the cues and triggers, analyzing any past relapses, the goal is to try to increase their confidence, their self-efficacy, that they can handle or avoid certain things. Sometimes these are specific examples of things that are worked on. Mindfulness is now becoming a common tool in helping co-occurring disorders and substance use. Sometimes it's just the mindfulness of being more mindful and listening to people better, but it could also be things like the mindfulness-based cognitive therapy that Carl Fulweiler talked about recently. We add mindfulness into our dual recovery therapy approach. DBT has mindfulness in it. Mindfulness-based relapse prevention by Alan Marlott, MBRP, is one that's used for lots of different addictions and more commonly not tobacco, although tobacco has also been used, this has also been used for helping people with tobacco. There are apps, websites, MP3s. Our own Judd Brewer here at UMass developed the app Craving to Quit. This can be a great app for mindfulness and tobacco cessation, and I love this little acronym of RAIN as an example of people recognizing they have a craving, not seeing that means they have to use, but seeing it more like they want to understand it better, accept it, investigate what's going on, and know that it's going to go away. So there are definite mindfulness strategies that can be used in substance abuse. For quitting smoking, there's the phone lines, 1-800-QUIT-NOW. There's a number of online resources where you can get cognitive behavioral therapy online. BecomeAnX.org, quitnet.com, FFS, the Freedom from Smoking Online.org. That's the American Lung Association's model. Then local treatment groups, we have them at UMass Memorial Treatment Services, and NICA is also available. Like any other 12-step facilitation, you help people, if they're doing this model, to work their program, to engage with their network, find a sponsor and a home group, which could be online or on a phone. The fellowship, that sense of connection with others, is even part of that spirituality. And labeling oneself as an alcoholic or tobacco addict user is encouraged to address denial, minimization, and rationalizing. If someone's working their program, these are the common components of someone working their program. They work the steps, they have a sponsor or a guide, they get involved with their group, they're self-reflective, they think about spirituality, they do some daily readings or reflections, They're also focused on their health care later. It's important to celebrate successes and being of service to others who are trying to quit. So a lot of that is great recovery work that one person helping another. So Dual Recovery Anonymous is one type of 12-step program out there specifically for dual recovery, but any of the 12 steps have meetings where people are more accepting or less accepting of co-occurring disorders, so it's important just to find the ones in your neighborhood. For tobacco, here are some great resources by peer specialists. You might want to go to the njchoices.org website, which is consumers who have quit smoking, who share their stories and have lots of great advice and help to others. RX for Change has lots of website material and PowerPoints, and they have a 3-hour training program for peers that you might want to access. For pharmacology, this is general principles for any co-occurring disorder. Watch out for abuse liability, overdose risk, seizure risk, sedation, liver toxicity. As an addiction psychiatrist, those are things I'm thinking about. And I'm also usually delaying the onset of starting in case this is substance-induced. Typically start at lower doses and go slow. Obviously, you need to manage detox if that's the issue. Got to treat the specific problem, look for abuse liabilities, be as safe as one can be, and watch out for interactions with substances. There aren't a lot, but there are a few, like an MAO and stimulants. For pharmacotherapy in the mental health settings, you obviously have to treat the mental illness. There are psychosocial treatments and meds that are maybe important. How do you engage in a shared decision-making way? And then adding the addiction treatments. And there are many that are available for detox, protracted withdrawal, or maintenance, and they depend on the substance. So given our more limited time today, we only looked at one of tobacco, but one could have looked at any of the others. At the bottom of this, the AA member medications and other drugs, that's a great resource for anybody who's with co-occurring disorders to help them go into meetings and be able to be comfortable with sharing that they're on olanzapine or some other medicine that's clear for the psychiatric issue. For tobacco addiction, this is the typical algorithm we think about. What does the patient want? Consumer, whatever word one would use, client there, person at the center of a concern. What did they try in the past? Are there medical issues? How bad is the severity? Do they have breakthrough cravings, weight gain concerns? Those are all clinical factors. Typically, you might do a monotherapy, any one of the 7, but people typically do varenicline or the patch or one of the oral NRTs. Sometimes combination is used. The patch with oral nicotine replacement is a common one, or bupropion and nicotine replacement. How much nicotine replacement depends on how much they're using. Most doctors don't know what I'm telling you now. Each cigarette has about 13 milligrams of nicotine. The average person breathes in about 1, but there are subgroups. There are people who breathe in 2 to 3. You can see that from a CO meter or cotinine, but when we've done studies with people with schizophrenia, they tend to be at the 2 to 3 milligrams, so they really are effective and efficient of getting most of the nicotine in their body. So the math on the bottom, you can see somebody 3 packs a day, or like this guy was 2 packs a day. This person would have a lot of nicotine in them, and a little patch might not be enough. I've alluded to the interaction of tobacco smoke and psychiatric medication blood levels. For some of you as prescribers, this is vital and really need to know about it. For those of you as other clinicians or interested individuals, knowing that there's somewhere in the liver, the P450-1A2 isoenzyme, that affects the metabolism of these meds and many others. And when you smoke, you need more of these meds or more caffeine. And that when you stop, those medicine blood levels will go up, so you could get medication side effects. So if you're on Haldol, you might get more stiffness. If you're on Thorazine, you might get more sedation. In substance abuse settings, they're more reluctant to prescribe psychiatric meds, and so they worry about an interaction, and they worry about being manipulated. So in that setting, often we have to encourage the providers to actually use meds at some point. So this is the final slide, and this is the resource that had the 14 principles for prescribers. So I'm able to finish our formal presentation now, and we'll answer any questions that you all type in.